Welcome to Hello Therapy, a podcast to help you take charge of your mental health through evidence-based psychological tips and tools straight from the therapy room so that you can live life better. If you feel really trapped in obsessional doubt and the thought of doing exposure and response prevention fills you with absolute dread, then this is the episode for you. Exposure and response prevention, or ERP, is the current gold standard therapy of choice for OCD. But there is a lesser known therapy called inference-based CBT, or iCBT, that has an increasing evidence base. It is a purely cognitive approach and does not focus on stopping compulsions. I was really intrigued by this, so I invited Amanda Petrik-Gardner, a US-based licensed clinical professional counsellor and OCD therapist who specialises in iCBT. Amanda is the creator of the OCD exposure colouring books and the compulsive reassurance workbook. Amanda currently provides online therapy across various states in the US. In this episode, we're going to dive into the core components of iCBT, what it looks like, how it differs from ERP. So whether you're a fellow therapist or someone who experiences OCD, this episode promises to offer valuable insights and practical information. So let's dive in. Thank you, Amanda, for being here on the Hello Therapy podcast. It's great to have you here.
Thank you. I really appreciate you having me.
So we are going to talk about inference-based CBT or iCBT for OCD because that is your specialism, or it's one of your specialisms. I know that you do lots in the OCD field. So do you want to tell us a little bit about who you are and what you do?
Yeah, so my name's Amanda Petrik-Gardner, and I am an OCD specialist in the state of Kansas in the United States, but I'm licensed in multiple states here. So treating OCD and the OCD-related disorders, I've been doing that for about 15 years.
Okay.
And that's about it. That's me.
Yeah. And you're an author as well, aren't you?
Yes, just this past summer, had a book come out with New Harbinger Publications, a compulsive reassurance seeking workbook. And then years ago, I did the OCD exposure coloring book. So I have several volumes of that people are still
Amazing.
using to this day.
I haven't got a copy, but I didn't realize you did that, and I was like, oh my god, that's amazing, and some of my clients would love that.
Oh, it's fun. I didn't think it would catch on and still be around this many years later.
So let's start by getting to what is iCBT. Can you give us a bit of an overview? Because I think we were chatting before. In the UK, it's not very known, I don't think, because we tend to favour exposure response prevention, or CBT, more traditional CBT for the treatment of OCD. So it would be great to get an overview of what it is, if you could explain that to us.
Absolutely. So it is a cognitive treatment. It is an evidence-based treatment for OCD. That's a cognitive treatment, meaning it changes the way we think in order to change what we do. So as compared to exposure and response prevention, which is a behavioral treatment, which changes what we do, asks clients to do something different, which eventually changes how we think about our OCD. So two different paths that ultimately lead to the same goal. But with this cognitive treatment, I know for any clinician or clients that have done OCD treatment, we've been taught a lot, like you don't tackle the thoughts, you don't challenge the thoughts. And this in particular, iCBT goes after the reasoning process that constructs the doubts. It looks at how did these doubts ever come to be? We believe that our obsessions or our obsessional doubts aren't just random thoughts. They didn't just come out of the blue or fall out of the sky and plop into our head. They are actually inferences, which just means they're conclusions that our brain came to through a reasoning process. But through a faulty reasoning process, which we're going to help our clients see. Mm-hmm. So if I could make up an example, for the classic example, hit and run OCD, where somebody is driving and feels a bump and they worry, what if I just hit a pedestrian? we see that this thought isn't just random. It wasn't just an intrusive thought that popped into their head. It was a conclusion based on a line of reasoning. Now, it happens very quickly. Within a
Mm.
millisecond, they have this idea that that could have been a person. And if we could see the story, the logic that OCD has behind it, it says, well, you did feel a bump. And maybe you did see people walking alongside the road. So it could have been one of those people. And maybe you weren't paying the best of attention. You were, singing to some music and you zoned out. And, what if you are just this horribly irresponsible, inattentive person? And you have heard stories, on the news before of people that have like hit a pedestrian before and killed them. What if that could possibly be you? And that quickly, this very compelling, convincing narrative
Mm.
pulls us into this doubt. It makes it feel so real that we are now stuck on an obsession.
Yeah. So it's very different, isn't it, to the sort of cognitive appraisal model of OCD, which is that intrusive thoughts are that everyone has them, that they're normal, and that in OCD they just kind of stick around too much and you make meaning out of them. And it's the meaning or the appraisal of it that's the problem, not the intrusive thought itself. But iCBT doesn't really talk about intrusive thoughts. Am I right? It's very much focused on the obsessional doubt.
Right. We say that the obsessional doubt is actually an inference, meaning a conclusion we've come to, as opposed to an intrusive thought. Now, of course, just to make things complicated, because nothing's ever easy, we don't deny that intrusive thoughts exist. I mean, there's research that shows everybody does have intrusive thoughts. We just don't believe our obsession is the intrusive thought. An intrusive
Okay.
thought could trigger an obsession, but lots of things could trigger an obsession. That bump while I'm driving could trigger the obsession.
Mm.
Something I see on the news could trigger an obsession, just like an intrusive thought could trigger an obsession. So tons of things could
Yeah.
trigger an obsession. We just don't think that obsession or obsessional doubt is an intrusion. It's an
Okay.
inference because there's a reasoning process behind it.
Right. Right. You mentioned there the evidence base. I was explaining to you before about we have nice guidelines, and as clinicians, we have those guidelines that we follow. And that's all about ERP and
Mhm.
CBT for OCD. That's the most effective treatment according to the research. So it'd be really helpful if you could give us a sense of like where the research is at in terms of ICBT at the moment.
Absolutely. And bear with me because I'm not a research person, so I'll do the best. And for anybody that wants to delve into it deeper, I recommend going to the website icbt.online. All the publications are listed there. But there's over, I want to say 90 studied. There's publications listed on there. Not only are there a handful of randomized control trials comparing iCBT to ERP, showing that it's just as effective, not showing it to be any better, but showing it to be as effective. But in addition to that, the core mechanisms that are showing why iCBT is effective, the core mechanisms being inferential confusion, which we can discuss,
Mhm.
or the feared possible self. These are big components of why iCBT is so effective. There are numerous studies showing why these have been effective. So the research is there as well, not just on ICBT alone, but on inferential confusion as a
Okay.
construct and the feared possible self and real self.
Okay. So yeah, that leads nicely into my next question about what is inferential confusion?
Yes. So, because big term, these are not words before I learned ICBT that I walked around using. Obviously,
Yeah.
as I mentioned, inference, a conclusion we come to. Then we have inferential confusion, which is when we start to mistake or confuse imagination and reality. So I always like to, when I'm working with clients, first really make sure they understand what inferences are
Yeah.
before we describe inferential confusion. So if I can give a little example, all of us are probably in a room or an office somewhere. And if you were to hear all of a sudden a big bang on your wall, what's the first
Mhm.
thought that comes to your head, right? What would you think it is?
That my teenager has knocked something off somewhere.
I love
Or
it
has
because
hit a football inside.
I always think it's probably my toddler. They just threw something. And other people, clients might say, oh, it's my dog just knocked something off. Or, you know, Another client might just say it's a murderer. So first to explain, these conclusions that we're coming to are inferences. But those, again, those inferences aren't just random. You didn't randomly think it was your teenager. And I didn't
Yeah.
randomly think it was my toddler. Or this person didn't randomly think it was their dog. And so I talk about how did you come to that conclusion? Because that's the reasoning process that in treatment we're going to be exploring. So
Okay.
you might have come to the conclusion it was your teenager because, oh, sometimes he's throwing around the football and
Yeah.
he does.
Indoors when he shouldn't.
And even though mom's told him not to. So there's a
Yeah.
reasoning process there. But for the kind that says it could be a murderer, they also have a reasoning process that says it's just possible. It could be. I watched this Dateline episode once, or I saw this documentary, right? And so those are inferences, and we all have them, and there could be several at once. Now, inferential confusion is when we start mixing up what's really happening for imagination. So even though you know it's your teenager because you just heard him or you now see the little football rolling in, you are still stuck on this idea, but it could be a murderer. It's just possible, right? Because I have
Yeah.
seen stories like that before. So now we're confusing these worlds, this world of what if and possibility for here's what I know to be true. And inferential confusion, anybody can be inferentially confused, not just people with OCD, but we see people with OCD have much higher levels of inferential confusion. So there is a questionnaire to kind of get your score and see how clinically elevated people with OCD are. But anybody in this world gets inferentially confused at times. And our goal through iCBT is to decrease that, is to help them recognize what is happening here, help them learn to trust in their senses and their self, to learn to not rely on possibility as much unless there's direct evidence to say so, and a
Okay.
bunch of other skills. So
Okay. What's your experience in thinking in terms of, as you say there we can all become inferentially confused. So what is it that makes people who experience OCD, like, why would someone go down the OCD route versus just, oh, I'm just inferentially confused, and it doesn't lead into an OCD process? What's your sense of that?
great question. So it would probably help if I explain there's like three big components that are more likely to lead to inferential confusion. And
Okay.
so we see that people with OCD tend to exhibit these kind of processes more often versus those that don't. It doesn't happen as much. So the three big components of inferential confusion I started to mention before: possibility. People with OCD tend to rely on remote possibility a lot more. So just the fact, well, it's just possible. It just could, just maybe, just, it could happen
Right.
tomorrow. Whereas people that are less likely to get confused about these things, just because it's possible, they don't act on it. Right.
Mm-hmm.
So that's a big one. So again, with treatment, we're really helping them see how we don't act on possibilities just because stuff is possible. Think
Yeah.
about all the millions of possibilities that are around us at this very moment. It's possible I could have a heart attack. It's possible my chair could break. It's possible the roof could come down on me. But we're not acting on every possibility at any given moment until something tells us to do so.
Yeah.
Except with OCD. OCD says, oh, just act on it. If it's
Yeah.
possible, we should do it. Possibility is a big one. Distrust of our senses and ourself is another component. OCD is always in our ear saying, you can't trust that. You can't trust what you just saw. You can't trust what you just felt. You can't trust who you are. What if you really are an evil person and you don't know it? What if you
Yeah.
really are just an immoral person? Or what if you can't trust what you just tasted? Maybe your drink really is, full of poison. You can't really taste it. So it's always saying you can't trust anything. Whereas those that are less likely to be inferentially confused walk around the world trusting in themselves. They know who they are and they trust in that. And they walk around trusting what their perception tells them, what they see and feel and hear and so on. So we're helping to resolve that component too.
Okay.
And the third one, it sounds fancy. It's not. I'll explain it. Irrelevant associations, simply put, are things that are true on paper, facts, stories that maybe have happened to you in the past or to other people that OCD likes to grab onto and say, so it must mean it's happening to me. It likes to say, well, germs are in everything and they're invisible and they're airborne or they're spread on surfaces. So that must mean I'm contaminated. Or it says, but Amanda, you could hit a pedestrian because there was that one time you hit a squirrel. So it
Yeah.
uses bits and pieces of information that is more or less true to try to make our doubts seem true right now. So we have
Mm.
to help see how it's using this information out of context or in an irrelevant way.
Yeah. And it's that, as you say, that sort of the construction of the story, the narratives
Mhm.
around all of that, in conjunction with that element of distrust in yourself. And
Mhm.
that's so huge, isn't it, for people with OCD? I think what I've noticed also with people who experience OCD, they have amazing imaginations. So I think if you
Yes.
have that ability to really let your imagination run wild, then maybe you're sort of more at risk for being inferentially confused, would you say?
I absolutely agree. And I don't know the research on that as far as
Mm.
OCD and creativity, but I see it with
Yeah.
clients all the time that we, as somebody with lived experience, can create an obsessional story for days. A story that just says,
Yeah.
but it's possible. It could be. And here's what I've learned, and here's what I know, and here's about this person I read, and this person in my past, and put it together.
Yeah.
You've got one compelling narrative that will suck you in. And when a story is has enough emotion surrounding it, feels fearful enough, you live in that world. You start to act on that world. Even though, and almost every person with OCD will be like, I know it's not happening. I know it's not really occurring. It's not logical. It doesn't make sense. It's
Yeah.
silly. But what if? And that's
Yeah.
us. We're going to live in that story, even if we know it's not happening, because it just sounds convincing enough.
Mm. Yeah, and that statement, isn't it, that I hear all the time in sessions, which is what you just said, that I
I
know it's
know.
not true, but I can't help it, or I'm just so stuck in this idea or this anxiety, and it's so frustrating for people to experience that, and it then leads into like the frustration at themselves, and then there can be lots of self-criticism. I'm really interested in self-criticism and OCD as well, and so there can be a whole load of things that show up for people just in the process of the doubt and the symptoms around that.
Mhm. And I still do ERP with clients as well that request that. But one part that I really love about iCBT is it helps restore that trust in who they are, who they know they are, because they'll say, I
Yeah.
know I'm not this person. I know I'm a person of faith, or I know I'm a nice person, or I'm a responsible person. And they should get to know that and trust that too. Just like everybody else in the world that doesn't have OCD, they get to just know who they are and trust that.
Mm. Mhm.
And we can restore that sense of trust, just like everybody else in the world has. I personally don't feel like we need to make them sit with an uncertainty of who they are because we don't ask the general population to
Mm.
do that. So it's kind
Yeah.
of cool that people are now getting to have certainty in who they are because everyone else does.
And there's another element of ICBT, which is this concept of, is it the feared self? I don't know if I'm using that term right.
Yeah. So the fear of possible self, and I jumped
Mm.
ahead because I kind of started talking about the real self. So this is one of the other core mechanisms that we have found unique to individuals with OCD is they have another doubt. So in addition to their obsessional doubts that are like, what if I could murder my spouse? Or what if I could hit
Mm.
somebody with my car? Or what if my drink is contaminated? There is another doubt. I say the bigger
Mm.
doubt, the mother of all doubts that's underneath it, kind of connecting all of these together. That is actually a doubt about who they are, a
Okay.
doubt about what kind of person they could possibly be. And this is called the feared possible self. And it says you could possibly be somebody who is blank.
Yeah.
And it could be a variety of things. For me and my themes, it's somebody that could be negligent. And what's
Mm.
interesting, every obsession always ties back to this, whether it's the fear that my child could be sexually molested. It comes back to, well, you'd be such a negligent mom if you don't know that's happening. If it's my
Yeah.
contamination doubts, it's, well, you're such a negligent person if you're getting dirty. If it's
Yeah.
my fear that, what if I'm gay and I'm in the wrong marriage? Well, it must be because you're negligent and you don't know your sexual orientation.
Mm.
Every single doubt comes back to my feared possible self.
Okay.
But there's a lot of different feared possible selves. It might hit on something like you could be somebody that's evil or a monster or violent. It could be, again, you're impure, unclean. It could be you're immoral or unethical. And so we have to explore what that person's is. And what we find out is it goes completely against who their real self is, which makes sense because somebody who's actually negligent is not going to be like, oh my gosh, what if I could be so negligent? No.
Yeah.
It's actually the person who's the most responsible or, is, conscientious and attentive, that's why it's so fearful that they could be something else.
Yeah. And is it that we all have a feared possible self, or is this just for people who experience OCDs?
Good question. So this is where there's a lot of different terms. They've labeled the feared possible self, this doubt, this kind of obsessional doubt is unique to OCD, but there are concepts called the vulnerable self or feared self. We recognize everybody has this. Everybody has that thing that they're vulnerable or sensitive to being. However, not everybody gets stuck on that.
Yeah.
And so that's where the feared possible self comes in. And this is a doubt saying you could actually be that thing. So the feared self or vulnerable self, anybody has that thing that's like, they're just very sensitive to the idea of becoming that. But then OCD takes it to another level saying, oh, but what if? But what if you could be that person? And here's a whole story that says why you could be that person. And that's the part they have found is unique to OCD, where we get stuck on this idea as in another obsessional story about that.
The thing that I've noticed in working with people over the years is, with people who experience OCD, it is that extreme end of things in terms of like, I'm a criminal, I'm a bad person, I'm a paedophile, I'm this, I'm that. Whereas someone experiencing anxiety or worry, it doesn't tend to go to that extreme. At least that's what I found.
Absolutely. As most obsessional doubts doesn't see kind of the gray area like, hey, sometimes I make mistakes. It's, you are this horrible, irresponsible person. Absolutely. So obviously our goal with iCBT is to resolve that and help clients discover their real self, which is who they authentically, genuinely are, which is not just one characteristic. It's a compilation of who they are, how they show up as in reality, observations from others, their history, their everything. And as I kind of already alluded to earlier, help them get to trust in that, just like everybody else gets to.
So can you give me a sense, because I've been reading the books and looking at trainings online, can you give me a sense of what a session might look like? I know that there are modules or steps, aren't there, in the treatment, but can you give me a flavour of what an iCBT session might be like?
Yeah. And this might be different from clinician to clinician, but I'm a little bit more structured with iCBT. There are modules, so step by steps we kind of go through. I tend to use a lot of exercises, kind of experiential activities, and want to make sure clients understand the materials. So there is some psychoeducation. So, in the beginning, it might be teaching some terms, using, again, different activities to help them understand the concepts.
Yeah.
And then once they understand the concepts, we'll go through some practice in session to apply the information, typically to OCD themes that are not their own first. Because all the information, it can be it's sometimes easier, more helpful to first apply it to something that's not their doubt. Because it almost makes more sense when we're saying, let's use it for a doubt that you don't doubt. Because it's like, oh, that makes sense. Of course. And then we say, let's apply it to your doubt. Because we all think, well, but my doubt's different. But my doubt's harder. And so it can sometimes help to start with something that's a non-OCD doubt.
Okay.
But sessions, while it's kind of structured as far as like the modules are concerned, and sometimes we go out of order if your clinician, has a different preference. It's a lot of exercises, activities, practices. Maybe people are using videos, sometimes some PowerPoints, just kind of depends on clinician to clinician. But we never want to move on to the next module until you fully grasp the steps before. Because if you try to go too fast and don't understand what we learned before, You're
Yeah.
going to get lost. So, but a lot of times it's kind of a session per module, give or take. Sometimes you might need a few sessions if it's a really hard topic.
Yeah. That structure can be really helpful,
Mhm.
can't it? And as a clinician, to knowing what you're doing next. Whereas I think with working with people with OCD, there's such complexity, isn't there? You can be working with someone with contamination fears, for example, but it's not just that they're coming with contamination fears. They've got histories, they've got other problems going on, they've got all the context of their lives. And I think with a structured approach, I'm guessing you would hone in on the OCD experience, would you?
I tend to, obviously, making room for times when we have something else that pops up that takes
Yeah.
precedent if they want to discuss something that's going on this week and we have to take a pause in iCBT,
Mhm.
or if we need to refer out for something else, we have to be flexible there.
What would you say have been some of the challenges that you've come across personally in sort of implementing this type of therapy?
Yeah, that's a really great question. So, challenges, this is very different than ERP.
Right.
And in case any listeners are thinking, oh, I could see how they could be used though together, the way it conceptualizes OCD is completely opposite. I mean, one is saying you have to be uncertain, sit with uncertainty. And one is saying we actually do have certainty. Clients will say,
Yeah.
I know, it's fine. And one is saying, let's do exposures and, induce anxiety. And the other is saying we don't have to do any exposures. We don't have to raise our
Mhm.
anxiety. And so that can be difficult if somebody's already come in with that knowledge, right? And so it's almost like teaching them something totally opposite. But honestly, I've rolled with that so well and just said, you already have that information. You've done ERP, keep using those tools as you like. What's worked for you? I'm just going to teach you something totally different that might even contradict some of the things you've already
Mhm.
learned. Um, Otherwise, only another challenge is it is a very, again, cognitive treatment. It's going to make you think. And if that is not somebody's forte and they don't want to, sometimes we get a feel for clients and they are just more of a behavioral person. They say, I just want the
Yeah.
challenge. Tell me what to do and I'll do it. I love to be challenged and do the hard things. And then
Yeah.
you get a feel that they might be just more appropriate for ERP. And I love that.
Mhm. Mhm.
Versus some clients will come in saying, no, there is a story. Like, there's a reason I'm doing this. There is a why behind my obsession. I know why I'm doing this stuff. And I'm like,
Mm.
oh, this cognitive
Yeah.
treatment might be a better fit.
Yeah, because ERP isn't a good fit for all people who experience
Mhm.
OCD, is it? And it's a very challenging treatment, and it's really difficult for a lot of people. So I think that there's a real appeal with a sort of more purely cognitive therapy. Is there like a type of difficulty or problem or client that it fits the most, this particular model, ICBT?
Yeah. While seeing benefit with all themes, it's made for OCD in general. So
Yeah.
anything that comes with that, I definitely found. I mean, the research has shown it does well with overvalued ideation. So,
Right.
meaning like when clients are just firmly believing in their obsessions as if they're true. So, that's great. We've noticed when there are strong taboo themes, and I think it's because of, I mean, couple reasons. Not only because it actually addresses that fear of possible self that it hits on and helps them learn to trust in who they really are. So I think about the things like pedophile OCD or the harm obsessions. It actually addresses that. It doesn't necessarily say, you have to sit with the idea that you could be a murderer. And so
Mm.
it actually helps them recognize, oh, I'm not that person, but
Yeah.
also because there isn't that need for exposures to that. So
Mm.
I think it helps them see how that doubt was even born. And if they are no longer absorbed into this obsessional doubts, then none of the anxiety even exists. So exposures there weren't needed. So I have found the taboo themes have especially been beneficial, but to each their own. Both treatments, again, we have found to be beneficial for all those themes. But those are the ones I really enjoy doing ICBT
Mm.
with.
And yeah, like a central thing of the model is yeah, as you said, you get rid of the obsessional doubt and everything
Mhm.
else falls away. Like there's no need
Yeah.
for compulsions. Is that
Mhm.
is that really how it happens in sessions all the
Yeah.
time?
And I should have probably explained all this at the very beginning, kind of what we describe as the obsessional sequence, meaning here's the order that we say kind of OCD follows. So, since, an obsessional doubt is an inference, it's a conclusion, it's triggered somehow. And I kind of mentioned this, whether it's triggered by you see something on TV or it's triggered by something you're sitting there thinking about, you're lying there at night
Mm.
and thinking about something, and then the doubt is triggered. So we got this trigger that prompts the doubt. Well, after the doubt, obviously there's consequence to the doubt. It results in something. Otherwise, we wouldn't be scared of the doubt if there weren't some kind of consequences.
Yeah.
And then there's the anxiety that ensues, the emotion, the discomfort, the distress because of those consequences. Again, if there wasn't some kind of distress, we wouldn't care.
Yeah.
And then as a result, then comes the compulsions. So we feel compelled to do something to make all those uncomfortable emotions go away, to make sure those consequences never happen, to resolve that doubt.
Mm.
So, what we mean by if we resolve the doubt, everything else goes with it, is that the ICBT is an upstream treatment, meaning we are targeting the very beginning of this sequence. Now, by the very beginning, we can't get rid of triggers. Triggers is the one part that never changes.
Right.
Triggers just exist in life. So that's staying the same. But we're doing the next best thing is we're figuring out how did we go from the trigger to the doubt? We're changing the relationship from the trigger to the doubt. If we can resolve that, well, and we're no longer buying into this doubt or this story, we're getting sucked into it, well, then those consequences we once feared are no longer relevant. And if we're no longer fearful and absorbed into this doubt and fearful of these consequences, well, then the distress never happens. And then
Mm.
again, then these compulsions never happen. As opposed to, just for an example, ERP is a downstream treatment, meaning it's addressing the anxiety and the compulsions. It's doing exposures to habituate to anxiety, and it's doing response prevention to resist the compulsions, which again is great. It's an effective treatment, but it's downstream. It never resolves the obsessional doubt. The obsessional doubt is still there, which is why a lot of people are left lingering with this. But
Yeah.
why? But what if? But I'm
Mm.
still wondering this thing. So we're getting to the root of how did this doubt even come to be?
Mhm. So would it be that by the end of treatment, somebody would they still experience doubt, but it wouldn't be as strong, or they wouldn't buy into it so much? Or is it that it
Mhm.
kind of all just disappears?
So it could be a few different experiences as they make progress. So in
Okay.
the beginning, as they're going through, as they finish treatment, they might have the doubt, but they're starting to recognize the story. What is OCD saying to pull me in? And they're starting to recognize the tricks that OCD uses. Oh, it's using these out of context facts to pull me in. Oh, it's using just the fact that it's possible to lure me in. Oh, it's telling me I can't trust myself or I can't trust what I just saw. So we're kind of opening their eyes
Yeah.
into recognizing what is happening. Like we're really slowing down the process enough
Mhm.
so that then they have like an active choice in this moment to decide, what do I do next? I
Yeah.
can go into what we call the OCD bubble, where our OCD lives, where the compulsions live, or with the information I have, right? With what my senses are telling me, with what I know about myself,
Mhm.
here are the other choices that I can make. So at first, it's still a lot of practicing the steps, slowing it down, making an active choice. And as we know, with any kind of practice, that goes quicker and quicker to the point that now, when I have a doubt, I'm really practicing my disgust based contamination stuff right now. That when I have a doubt, I can be like, well, what's the story? Oh, it's using that against me. I know that trick.
Right.
And I can resolve it within a few minutes. But in the past, I would get absorbed into this doubt
Mm.
and I would just be like, heck no, I'm avoiding. And so
Yeah.
we're really slowing down that process enough that they can start to kind of see what's really behind it, kind of like taking off the veil or taking off the filtered glasses and seeing what really is there.
Yeah. What you were describing there, it does sound a bit like acceptance and commitment therapy or ACT. Do you practice ACT?
I practice ACT. Which part?
Well, I guess I was thinking about, I use the choice point a lot, Russ Harris's choice point, that idea of like stepping back and like, which direction do you want to go in here? What are you being pulled into? What's the story? Can you look at your thoughts? Can you observe them? And so that sounded very familiar to me.
Yeah, there is, one module where it kind of uses this idea of like two different paths. They use this metaphor of like on a bridge and you're in the middle and you got two directions you can go. Can we catch the moment before we choose to go into the OCD bubble? Because sometimes it feels like it just happens to us as opposed to helping us kind of take some, have some accountability here or see some agency here that we can actually decide which way to go. So I can see that idea there where it's like there's two directions we can go here, and helping them see one side is the OCD bubble that is built in the imagination, right? Where inferential confusion occurs. And the other side is the here and now, which is everything, all the information we know to be true.
Yeah.
And of course, we're going to be providing them a lot of skills to trust in that information.
So would you say, is there anyone that this type of approach isn't suitable for or doesn't quite work? Have you come across that in your experience, or is it actually that everyone can benefit from this type of approach?
Yeah. I haven't turned anyone away from iCBT yet, though it's not an evidence-based treatment for children yet.
Okay.
With that said, I say yet, it's just because the research hasn't been conducted on children. And so right now, I know some clinicians are using it on teenagers. We really have to just look at, is somebody cognitively able to do the work? And so that's just one thing we kind of look at. As far as other exceptions, I personally haven't found we'll see.
Yeah.
No exceptions on themes.
And it would make sense. It would need to be adapted, wouldn't it, for children? You'd need to, because some of the concepts are quite cerebral. And I'm sure that it, with the modules, it explains it well. But I think
I agree. And there are some clinicians that are already adapting some of this material for children. And so on the iCBT website, there are some resources already for that. Each clinician kind of decide if they start using it for that age range, since the evidence is not quite there yet for them.
Yeah. So anyone listening who experiences OCD, what do you want them to know through an iCBT lens?
I just want everybody to know that there are options. As both you and I had discussed previously, that none of these treatments are 100% effective. And it's really nice that for those clients that maybe did one route or another and did not see the progress that they were hoping for, even though they were told, this is the treatment we all recommend. It's really exciting and hopeful to know that there's other options available. Yeah. And it's not because they didn't do a good enough job, right? Because that's the thing that always breaks my heart, is when we try to say the client just didn't work hard enough, or even blaming the clinician, saying, well, the clinician just must not be trained well enough. Well, there's also just a percentage of clients that don't respond to some treatments. Yeah. And we should be able to offer them other options. And hopefully every clinician, every OCD specialist will do that.
Yeah. Well, it's been fascinating talking to you about this, Amanda. Thank you so much for coming on today.
You're welcome. And if you have any questions, or any listeners do, I'm so excited for people to learn more.
Thank you for listening to this episode of Hello Therapy. If you found it helpful, don't forget to subscribe, follow, and review. You can get more well-being and mental health tips by joining our email list and visiting the resources section of our website at harleyclinical.co.uk. The Hello Therapy podcast and the information provided by me, Dr. Liz White, is solely intended for information and educational purposes and does not constitute personalised advice. Please do reach out to your GP or a mental health professional if you need support. Until next time, take care of yourself.